Okay, I think we're ready to make a start here. Thank you everyone for joining us. So hello everyone, happy Halloween and welcome to this lab webinar event brought to you by Diaceutics and LabRoots. We are thrilled to have you with us today and taking the time out of your busy schedule to join us. We look forward to bringing you more speakers and more events through this precision medicine in solid tumors virtual space in the coming months. Today we feature Dr. Gulisa Turashvili from Emory University, who will be discussing gynecological and prognostic and predictive biomarkers. So to begin, here's our agenda for the day. My name is Justin Lehman, a DXRX Lab Relations Team Lead with Diaceutics. I'm going to give you a brief introduction to Diaceutics as well as our precision medicine platform called DXRX. I will then hand things over to Dr. Turashvili for her presentation. And finally, we will have some dedicated time for Q&A. So Diaceutics is an data analytics and end-to-end service provider specialized in precision medicine. Our mission is better testing, better treatment, and we strive for a future where the testing ecosystem enables all patients to receive an appropriate treatment as soon as possible. We believe that labs need to be involved earlier in the decision-making process in the precision medicine ecosystem. And we have experience working in 96 different disease pathways and have worked on every precision medicine brought to market with a top 36 of 40 pharmaceutical clients. We have a global presence across 53 countries, enabling knowledge sharing across a vast range of topics. Laboratories, pharmaceutical companies, and diagnostic companies can all find benefits from being registered users on DXRX, and we see our collaborations and our offerings having a positive patient impact around the world. We seek to break down any barriers in the lab community at a global level, and the best way to do this is allow all labs to access the DXRX network. So a DXRX lab membership enables you to be the first to hear about exciting scientific studies and DXRX collaborations, be a part of our data-driven recommendations to increase your visibility to other precision medicine stakeholders, and access lab talks, lab webinar recordings, podcasts, and DXRX Live newsletters. Following this live event, we encourage you to navigate to the exhibit hall within this space to view the DXRX booth for more information. We also encourage you to sign up to DXRX and become a part of our laboratory network. It is now my pleasure to introduce Dr. Gulisa Turashvili. Dr. Gulisa Turashvili is an associate professor in the Department of Pathology and Laboratory Medicine at Emory University School of Medicine. An anatomic pathologist, Dr. Turashvili specializes in gynecologic and breast pathology. Dr. Turashvili is a member of the Cell and Molecular Biology Research Program at Winship, and she's also a member of multiple committees, including the Anatomic Pathology Quality Assurance Committee at Emory University Hospital, the Emory Alliance for Women in Medicine and Science Steering Committee, the Pathology Work Group of International Gynecologic Cancer Society, and many more. Dr. Turashvili, thanks for being with us today, and the floor is yours.
Thank you so much, Justin, for this nice introduction, and thank you so much for having me here today. Good morning and good afternoon, depending on where you are. And today we are going to talk about prognostic and predictive markers in gynecologic pathology, and talk about some of the issues that come up with treating our gynecologic cancer patients. This is the outline of the talk that will include brief definitions for prognostic and predictive markers. And then I'll be focusing on HPV testing, PD-L1 testing, MMR protein testing, P53 and poly, as well as HER2 testing. And I'll conclude with HRD and FR alpha testing. So just starting with definitions, before we talk about prognostic or predictive markers, it's important to know what the definition of each of these biomarker is and how prognostic markers can be differentiated or distinguished from predictive markers. So simple definition would be that a prognostic marker is any measurement that is associated with clinical outcome if patients are not treated, or if they are given some sort of a standard therapy, depending on what type of cancer they have. So said in another way, prognostic markers really reflect the natural course of the disease. In contrast, predictive markers can be any measurement that is associated with response or lack of response to a particular therapy that is given to a particular type of cancer. So thinking about treatment anytime we talk about predictive markers, and thinking about natural history when we're talking about prognostic markers. And the outline of the talk is really represented here as a diagram where HPV status and PD-L1 status are more important in the lower female genital tract. MMR protein immunohistochemistry, P53 poly, and HER2 testing would be more applicable for endometrial cancer, and HRD testing and FR alpha testing would be more applicable for ovarian cancer, although there is some overlap, as you will see shortly. So starting with HPV testing, as you may know, in the latest classification of female genital tract tumors, one of the important changes that was made was pathogenetic classification of cervical cancers and precursor lesions and vulvar squamous cell carcinoma and precursor lesions. Instead of simply classifying these tumors based on the histologic appearance, which would be adenocarcinoma, squamous cell carcinoma, all these tumors are now classified based on their association with HPV. So when we look at the cervix, we have adenocarcinomas, HPV-associated group, which is the most common, and then we have the uncommon HPV-independent subtypes, such as gastric, clear cell, and mesonephric. And when we look at squamous lesions, HSIL, the precursor lesion, is usually HPV-associated, and most squamous cell carcinomas in the cervix are also HPV-associated, probably around 90%. However, we now recognize that even when we use the most sensitive HPV detection techniques, there is still a small subset of HPV-independent cervical squamous cell carcinoma. So it becomes really important to figure out when you diagnose any cervical cancer, whether it's HPV-associated or not. And even more importantly, in the vulva, we have two major groups of squamous cell lesions, precursors and carcinomas, that is HPV-associated and HPV-independent. So how do we determine HPV status? As most of you, I'm sure, know, that P16 has been around for a while. P16 immunohistochemistry is considered a surrogate marker for HPV status, and we can easily apply a P16 immunostain to any biopsy or any surgical specimen that we receive in pathology labs. We can also use molecular methods such as my favorite, RNA in situ hybridization for high-risk HPV, as well as polymerase chain reaction, or PCR, which is not something that we pathologists do, but the molecular labs can obviously do PCR and genotyping, and they can tell us what type of HPV is associated with any given cancer. Just a short reminder about last recommendations for P16 immunohistochemistry. When it comes to precursor lesions, we don't just do P16 immunohistochemistry for any other reason other than the three that are listed here. We really need to have specific indications, such as when there is a differential diagnosis between HSIL, or high-grade squamous intraepithelial lesion, and a benign mimic, such as reactive changes or epithelial atrophy. We can also do P16 if there is a differential between LSIL and HSIL, so high-grade or low-grade squamous intraepithelial lesion. And anytime there is a disagreement between two pathologists, one thinks that it's HSIL and the other thinks it's completely reactive, or LSIL, in those cases, P16 immunohistochemistry can be helpful. So what do we look for? For positive P16, we look for block-like expression that is defined as diffuse, strong nuclear or nuclear cytoplasmic staining that should involve at least 1/3 of the epithelium when we're looking at precursor lesions. Negative P16, we can use the term negative, or we could say focal patchy staining or cytoplasmic only staining. But in terms of its interpretation, if there is complete absence of staining, and then if there is focal, patchy, or cytoplasmic only staining, for the purposes of interpretation for HPV status, these are really all considered negative. So what we look for is diffuse block-like staining. And again, if there is any doubt about, we can't tell if it's really diffuse and block-like, or maybe it's patchy, sometimes it can be difficult, then if you have HPV RNA in situ hybridization available in your lab, and if you don't, I would encourage, this is easy to bring, and it can be very helpful in the majority of cases where there is some disagreement or uncertainty about P16 immunohistochemistry. We can do this stain, and what we look for is nuclear and cytoplasmic staining. Sometimes it's really obvious, as shown on the left. It would be really impossible to miss this degree of staining. It's strongly positive. And on the right, you have sort of less staining where it's still obviously positive, but sometimes you need to go to high power to really identify those dots within the nuclei and the cytoplasm. And the degree of staining depends on the viral transcriptional activity. So even if it's weakly positive or focally positive, it would still indicate association with HPV. So it's important to examine your slides at high power in some cases. So now, some of you may be familiar with DNA high-risk HPV-ish or even PCR. And so we have all these tests available. We can actually, for any given case, we can use whatever tests we have available. But if I could choose, I would always choose high-risk RNA HPV-ish. And this table summarizes why that is. It's because it really is the most sensitive and specific technique that one could possibly use for high-risk HPV detection. And there are cocktails, for example, RNAscope has a probe cocktail where it covers about 18 subtypes of high-risk HPV. So that they really detect any common or even relatively uncommon high-risk subtypes of HPV that you may have in your tumor. So now, why do we care about the distinction of HPV negative and HPV positive cervical adenocarcinomas? This distinction is absolutely critical for patient management, and that has to do with the fact that HPV negative adenocarcinomas are more aggressive, they are larger, they are usually diagnosed in older patients. As you can see in this, progression-free and overall survival are much worse in HPV-independent cervical adenocarcinomas compared with HPV-associated carcinomas. And these are just some morphologic representative images of gastric type, clear cell, and mesonephric carcinomas that represent the three HPV-independent subtypes. They can be recognized based on the morphology in most cases. I will not go into the details of how to diagnose these cancers, but there are some cases where there is morphologic overlap, and it can be hard to tell if you're dealing with an HPV-associated adenocarcinoma or if it's potentially one of these HPV-independent subtypes. And it's important also to mention that some of these cases, for example, gastric type cancer is usually P16 negative, but there are some cases, I have seen some cases where it looks like gastric type adenocarcinoma and you do a P16 and it looks diffuse. And then really the only thing that would help you in that scenario would be HPV in situ hybridization or even PCR, anything that really gives you the information about HPV instead of using the surrogate marker P16. So false positive and false negative results with P16 can really be eliminated by having a molecular HPV detection method, whether it's HPV RNA-ish or PCR. I would take either over P16. So this is just an example of an HPV-associated endocervical carcinoma where you have this diffuse block-like expression of P16, and then we have positive RNA-ish, and then this typical morphology with hyperchromatic nuclei and apical floating mitosis and ATPI and so forth. So what about the vulva? HPV status is an independent prognostic factor also in the vulvar squamous cell carcinomas for progression-free and disease-specific survival. So said in another way, HPV negative squamous cell carcinoma has a worse prognosis compared with HPV positive squamous cell carcinoma. And really in 2023, this is how we should be thinking about vulvar precursors and vulvar squamous cell carcinomas. We can think about three clinically distinct subtypes. The largest group would be HPV-associated VIN or vulvar squamous intraepithelial neoplasia and carcinoma that's associated with it. Then we have a big HPV-independent category, which can be divided into two subcategories. One would be HPV-independent p53 mutant subtype, and the other would be HPV-independent p53 wild type subtype. So three major categories. And why do we care about this distinction? Again, it all has to do with prognosis. So when you compare recurrence-free survival among these three subtypes of vulvar cancer, the HPV-associated subtype has the best prognosis. HPV-independent p53 mutant subtype has the worst prognosis, and the HPV-independent p53 wild type subtype is somewhere in between the two subtypes that I already mentioned. And then again, we are not going into the details of morphologic features of HSIL, that's HPV associated, and DVIN, but they do have characteristic morphologic features. It's just more prominent atypia. If I had to summarize briefly, more prominent atypia for HSIL, mostly basal atypia in DVIN, and which is HPV independent, and prominent intercellular bridges. But there are many cases where you have a vulvar biopsy, you look at it, you know it's not invasive, it's an intraepithelial lesion or intraepithelial neoplasia, and you really can't make up your mind based on the morphology whether it's HPV associated or HPV independent because it has overlapping features of both. So then in those cases, and then I would encourage you even in straightforward cases, if you do P16 and P53, those two stains really will help you make sure that you're not misdiagnosing one subtype as the other because of the overlapping features in many cases. And that way it's sort of a QA or QC for your morphologic diagnosis. And the clinicians always look for this information. Now they are familiar with the subtypes, and they look for P53 and P16 in pathology reports. And if they don't say it, you might get an email from them or a call. So this is just an example of HPV-associated HSIL. I'm just emphasizing HPV association. If we use the term HSIL, it should be HPV-associated VIN. And so we see this diffuse block-like expression of P16, wild-type expression of P53, where there is no staining in the basal layer, but we have staining in the suprabasal cells. That's still wild-type. And then we have HPV RNA-ish that's clearly positive. And then we have DVIN or differentiated vulvar intraepithelial neoplasia, where on the right lower corner, we see this basal atypia that I was talking about and prominent eosinophilic cytoplasm and intercellular bridges. Morphologically, I would probably favor DVIN based on this morphology, but I would still do, as I said, P16 and P53. You can see focal expression with P16 and aberrant diffuse overexpression of P16. So that's aberrant expression. And then some examples of HPV-associated squamous cell carcinoma with diffuse block like P16, wild-type P53, and positive HPV RNA-ish. And similarly, HPV-independent squamous cell with aberrant diffuse expression of P53 and focal expression of P16. Morphologically, it will be really hard to tell unless you have a precursor lesion. It will be really hard to be absolutely confident that you're dealing with HPV-associated squamous cell versus HPV-independent. There are other mutant P53 patterns in the vulva, in the precursor as well, lesions, as well as squamous cell carcinomas. So if you only have basal overexpression as shown on the left, it's really all about the basal layer. So if you have strong diffuse staining of the basal cells, that's considered aberrant. So that would be in the right morphologic context, that would be consistent with divine, HPV-independent divine. If you have diffuse parabasal overexpression, so all the cells are staining, including the basal cells and all the suprabasal cells, that's also considered aberrant. Then if we have complete absence of staining, that's null pattern, that's considered aberrant. And then the rare cytoplasmic pattern, there may or may not be nuclear staining associated with it, but the predominant staining in less than 5% of cases can be cytoplasmic. And it can be easy to overlook this as non-specific staining, but no, it's actually been associated with a specific TP53 mutation. When we look at squamous cell carcinomas, we have four similar aberrant patterns that I just described. So the patterns are similar. I would just make sure that I'm familiar with these uncommon aberrant patterns so that when I have a difficult case, whether it's a bean or squamous cell carcinoma, knowledge of these staining patterns can really help you not to miss aberrant P53 expression. So to summarize HPV status, it's really important to do whatever you have available, whether it's P16 or PCR or RNA HPV-ish. In either case, HPV status should be determined in all vulvar, cervical, and vaginal squamous cell carcinomas. And in addition to P16, P53 immunohistochemistry should be done in vulvar squamous cell carcinomas and vulvar intraepithelial lesions to really figure out what we're dealing with. This is important for pathogenetic classification as well as prognostication. And as we'll see a bit later, this will also impact treatment decisions. So you want to get to the right diagnosis, and then you want the patient to get the right treatment based on the right diagnosis. And that's what precision medicine is all about. So now we are going to move to PD-L1 testing. So when I think of PD-L1 inhibitors or immune checkpoint inhibitors, the two cancers that come to mind are really cervical and endometrial, as well as vulva, as we will see in a second. Why do we care about inhibiting immune checkpoints? So immune checkpoints really prevent immune cells from attacking neoplastic cells. So if we block an immune checkpoint, such as binding PD-L1 to PD-1, that will allow cytotoxic T cells to recognize and attack and kill neoplastic cells. So you're familiar with immune checkpoint inhibitors, I'm sure. Based on Keynote 158 trial in 2018, the FDA approved pembrolizumab for advanced cervical cancer. So indication is PD-L1 positive, recurrent or metastatic cervical cancer progressing on or after chemotherapy. So we need to do PD-L1 immunohistochemistry to figure out whether any given cervical cancer is PD-L1 positive or PD-L1 negative. So PD-L1 expression is determined by combined positive score, or CPS, not TPS as in lung cancer. So CPS is what we need to think about. And what's recommended is the FDA-approved 22C3 clone on a specific autostainer. And CPS then is determined using these recommendations, which is that we count PD-L1 positive cells that include tumor cells, lymphocytes, and macrophages. We divide that by the total number of PD-L1 positive and PD-L1 negative viable tumor cells, and we multiply it by 100. And the maximum CPS is 100. And the cut point that we need to call any given tumor PD-L1 positive or PD-L1 negative is only 1. So 1 is all we need, and this makes me think of ER and PR positivity in breast cancer. So if we use this criteria, about 82% of cervical cancers will be PD-L1 positive. And in the trial, when this cut point was used, complete response was only seen in less than 3% of patients. Partial response was only seen in less than 12% of patients. So the current FDA-approved indications, again, based on that one CPS cutoff, are first-line combination therapy for advanced cervical cancer. Again, that's recurrent or metastatic, that's progressing on chemotherapy, and second-line monotherapy also for advanced cervical cancer. So those are the FDA-approved indications. So how do we assess the CPS? So if we have a really small specimen with only 20 cells present on a slide, we probably shouldn't be doing this. So an adequate specimen will have at least 100 viable tumor cells in a slide, so we can accurately estimate the CPS. So then sometimes there is heterogeneous staining. So, if we don't see staining in all the tumor cells, instead of picking hotspots, we really need to scan the entire section, especially if it's a big section, and really select representative areas and count those representative areas rather than going to the most positive area. So it would be a good idea to use a 20 times objective to make sure that sometimes there is focal expression that you may not capture at low magnification. So I would go to my higher magnification to make sure that I'm capturing at least even some focal expression in tumor cells or immune cells. So as I mentioned on the previous slide, we count lymphocytes, macrophages, and tumor cells. What's important to note is that lymphocytes and macrophages are only counted if they are associated with tumor. So if we see even large lymphoid aggregates away from the tumor, we should ignore those. So only association with tumor is what counts. And it doesn't matter if they are within the tumor, so if they're intratumoral or right at the edge of the tumor or peritumoral, they can be counted as long as you can reasonably say that these immune cells are associated with neoplastic cells. So if you have lymphoid aggregates within the tumor or at the periphery of the tumor, they are also okay. Again, it's really the association with the tumor cells that counts. So if you have stromal cells, plasma cells, or neutrophils that are staining, those should be ignored. And that really emphasizes the importance of looking at your H&D slide really well. And just sometimes it can be hard to tell if you have a lot of positive staining. And then if you're just looking at the immunostain slide, it can be hard to tell what type of cells you're looking at. So it's really good to have your H&D right there. And if you see some positivity, just go back and forth and make sure that you're counting the right cells, so the right type of cells. And so the tumor cells should have membranous staining. So that's the expected staining, as was shown on the previous slide. And the membranous and or cytoplasmic and immune cells would be acceptable. So if we apply this criteria, where we have this uniform staining in neoplastic and immune cells, and this case has a CPS of 100, so it's obviously positive. If there is no staining at all, that's also quite easy. You can say that CPS is 0 because really there is nothing to count. And if we have heterogeneous staining, as I mentioned before, one way to do this would be, we can count every single cell, but you can select 4 representative areas and then estimate your CPS in those representative areas and then divide it by 4. And that will give you an idea about CPS. So if we apply this rule, for example, to this case where there is patchy heterogeneous staining, this case has a CPS of 15, and keeping in mind that, whether it's 10 or 15 or 25, as long as it's more than 1, it's going to be considered positive. So 1 is really what one should worry about. If you're really close to 1, is it less than 1 or 1? That's the cutoff that we need to keep in mind when we score these cases. So if we only have staining in lymphocytes and not plasma cells, in lymphocytes and histiocytes, that can also be counted in addition to tumor cells, or if there is no staining in tumor cells and only immune cells are staining, as long as they are lymphocytes and macrophages and not neutrophils and plasma cells, you can estimate your CPS using the same formula, and in this case, CPS is 35. So this is just an example of how we report PD-L1 CPS. So we specify what kind of clone was used, and this is the FDA-approved clone 22C3. We'll indicate the block, and then we will indicate that it's more than one. So we don't really indicate the exact CPS. You could, but really the cut point that's used is one, and that's what matters. And then in the comment, we describe, or we sort of remind the clinicians that this is how we calculated CPS. And then there, sometimes there are some disclaimers that you need to include based on what your department or institution requires. So this report can look different depending on where you practice, as long as it includes the information about the clone and how CPS was calculated. So PD-L1 testing sometimes is also requested on vulvar and endometrial cancers, usually by clinicians. About 50% of vulvar cancers are PD-L1 positive, and there is no FDA approval for immunotherapy, but the reason that clinicians will ask for it is that there has been some response to immune checkpoint inhibitors in limited patients. So sometimes when there are no other treatment avenues, the patients will get immune checkpoint inhibitors. So obviously the clinicians would know if CPS is positive or not. So the current NCCN guidelines recommend pembrolizumab as a second-line, useful in certain circumstances option for PD-L1 positive or MMR deficient or MSI high advanced or recurrent metastatic vulvar cancer. So this is the specific indication for vulvar cancer. And in addition, PD-1 inhibitor, nivolumab, can be used for HPV-associated tumors. It's based on very limited data, but that's the recommendation. So you really can see, based on these recommendations, how figuring out whether your vulvar cancer is HPV-associated or not can and will affect treatment decisions for any given patient. So it's really important not to sign out cases as just vulvar squamous cell carcinoma. I put in the final diagnosis whether it's HPV associated or not, see comment, and then in the comment I would describe, whether you did P16 only or you did HPV-ish or PCR or whatever you did, that can be described in the comment. But the final diagnosis line should include like a couple of words about association with HPV, and that would be also compliant with the WHO classification. So endometrial cancers also express PD-L1 and PD-1 in about 80% of cases. PD-L1 expression is increased actually in MMR deficient tumors compared with MMR proficient tumors. Also, a study showed that Lynch syndrome associated endometrial tumors have a higher PD-L1 expression compared with MLH1 promoter methylated tumors. And this has to do with increased immunogenicity in the tumor cells due to neoplastic proliferation of the cells and production of some new antigens. So that's the explanation. But what's important to note is that for endometrial cancer patients, PD-L1 testing is not required. So as you may know, FDA-approved indications for immunotherapy for endometrial cancer really include MMR deficiency or MSI high status. So really eligibility of endometrial cancer patients for immune checkpoint inhibitors is based on the presence of MMR deficiency. And, about 30% of endometrial cancers and less than 14% of ovarian cancers are MMR deficient, but for those patients, this could be a treatment option. Another FDA-approved indication for immunotherapy includes advanced endometrial cancer, whether it's MMR deficient and or PD-L1 positive. So this brings me to MMR testing. So as you know, DNA mismatch repair proteins are one of the important DNA repair mechanisms because they repair insertions, deletions, mismatch bases during DNA replication, recombination, and DNA damage. So we need this repair mechanism. And what's important to know is that MMR proteins work in dimers, so MLH1 and PMS2 and MSH2 and MSH6. So PMS2 and MSH6 proteins are not stable if they are not paired with their partners. So what happens is that if we have MLH1 loss, that leads to MLH1 and PMS2 loss. And if there is MSH2 loss, that leads to MSH2 and MSH6 loss. So think of the pairs of MLH1-PMS2 and MSH2 and MSH2 and MSH6. So you see, if you say it fast, you can mix them up. But MSH2 and 6 go together. So what about MSI? What's microsatellite instability? So microsatellites are repetitive sequences that are susceptible to errors. So when there is a defective MMR and then your DNA repair mechanism doesn't work, that leads to high microsatellite instability. So if we do MSI testing and we see that the tumor is MSI high, so there is high microsatellite instability, that's really a reflection of some sort of an MMR defect, whether it's sporadic or germline. It's sort of a result of some sort of an MMR defect. So we can test for MMR status by mostly 3 methodologies that have similar performance metrics. So the most obvious and the most accessible one would be MMR protein immunohistochemistry, but also, of course, one can do MSI testing by PCR, and then next generation sequencing can give us an idea about whether there is a mutation or not in any of the MMR genes. So of these 3 tests, again, as I said, MMR IHC is widely available. I think most of the labs probably have it easily available, even relatively smaller hospitals or private labs. And it's easy to do this. It's easy enough to do this as long as we know how to interpret it, but it can also identify the most probable gene defect. And then we know that we look for, MSH2 and 6 together and PMS2 and MLH1 loss together. We can easily apply this to both biopsies and hysterectomies. And some of the issues with NGS is that it's not as widely available. Turnaround time can be longer. We may not get sufficient DNA from smaller specimens. Some MMR deficient tumors may be missed there. And then with MSI testing, I think a major problem is that it's not as sensitive in endometrial cancer as it is in colorectal cancer, so it may actually miss some cases. And so MMR IHC would really be the #1 test of choice to do in these cases. So as you know, what we look for is intact nuclear expression that would indicate that a tumor is MMR proficient. So we expect the intensity to be the same or higher as the internal positive control cells, which are always present in any, whether it's a biopsy or a hysterectomy, right? We always have stromal cells, and quite often we have lymphocytes. So we can easily tell if our test worked or not. And we can call this loss of nuclear expression if our internal control cells are staining, as shown here, and the tumor cells do not show any nuclear staining. So loss of nuclear expression indicates MMR deficiency. In terms of whether we need to do all 4 proteins or just a 2-protein panel, there was a recent study that showed that you can get the same results. 4-protein panel performs very similarly to the 4-protein panel because, as I mentioned, they work in dimers, right? So if we just do MSH6 and PMS2, that will give us a good idea about whether the other 2 would be lost. If one of them is lost, though, I would go back and do the other partner for this protein. But if both of them are retained, the tumor is most likely to be MMR proficient. So now MMR testing is performed for 3 indications, really 3 major indications: eligibility for immune checkpoint inhibitors, Lynch syndrome screening, and molecular classification of endometrial cancer. And it's just the prevalence of MMR deficiency seen in about 30% of endometrial cancers, and only a small proportion of them are Lynch syndrome associated. So, of course, it doesn't always indicate Lynch syndrome, but we look at MMR IHC in most cases as a screening tool for Lynch syndrome. Just don't forget that this could potentially be used for eligibility for immunotherapy by the clinicians, right, when they say that the tumor is MMR deficient. And this could be part of your molecular classification of endometrial cancer as well. So for immune checkpoint inhibitor therapy, the recommended test, again, based on the College of American Pathologists guidelines, is MMR-IHC, that is preferred over MSI testing or NGS, and tumor mutational burden alone should not be used. So MMR-IHC is number one. So, and then just most of you are familiar with this, but just to quickly summarize what we look for when we do Lynch syndrome screening. So if we have all 4 proteins that are retained, all markers are retained or intact, it's not likely to be a Lynch syndrome. If we have loss of MSH2 and MSH6, or isolated loss of only MSH6 or only PMS2, this is most likely to be associated with Lynch syndrome, and the patients go to germline testing. And if we have loss of MLH1 and PMS2 or loss of MLH1, most of these cases are associated with MLH1 promoter hypermethylation. So this is really sporadic MMR deficiency. To figure that out, we need to do MLH1 promoter hypermethylation testing. I think most places will do this reflexively. If methylation is detected, then the tumor is sporadic and not associated with Lynch syndrome. And if it's not detected, then the patients again go to germline testing. And so that's the flow chart that I think most places and countries follow. I just want to mention some of the unusual staining patterns that are considered loss of staining or MMR deficiency that come up in practice. That cytoplasmic staining or punctate staining, as you know, what we really look for is nuclear staining. If nuclear staining is absent, then it's MMR deficiency. And one important pattern to recognize is subclonal loss of expression. On this picture, you can see that most of the tumor has loss of expression. It's only the internal control cells that are staining. And then in the lower right corner, you see a proportion of cells that have intact nuclear staining. So this is subclonal loss. It's rare, but it can be associated sometimes with MLH promoter methylation that's subclonal only in that proportion of cells, or it can also be associated with Lynch syndrome related tumors or polymutated tumors. As far as eligibility for immune checkpoint inhibitors is concerned, CAP really recommends MSI testing of that MMR deficient area to maximize patients' eligibility for immunotherapy. And moving on to poly and P53 testing. So it's been 10 years since this TCGA paper was published that gave us the molecular classification of endometrial cancer. I will not have much time to go into this detail, but I will mention the most important points, that this classification was based on whole genome sequencing, copy number analysis, methylation, RNA sequencing, miRNA sequencing, protein array. So it was really integrated analysis. And the subgroups that were identified include polymutated, I think I'm going to move to the next slide, the poly or ultramutated subtype, MSI high subtype, copy number low, and copy number high subtype. So the main definitions for all these subtypes are as follows. The poly or ultramutated subtype has hotspot mutations in the exonuclease domain of DNA polymerase epsilon, and these are the most common exons that are involved. These have a very high number of mutations. They are microsatellite stable. They don't have high copy number alterations, and these are some of the genes that can be altered in this subtype. Most of these are endometrioid tumors, but they can have high-grade nuclear atypia. MSI high subtype, as the name suggests, is MMR deficient or has MSI high status. Most of them are methylated. They have few copy number changes and high mutation rate, but lower than the poly subtype. And most of these tumors are also endometrioid. The copy number low subtype really doesn't have too many molecular alterations going on. Beta-catenin mutations have been described, and most of them are endometrioid and low grade. Copy number high subtype, when I think of copy number high subtype, I think of serous carcinoma. These are microsatellite stable. They have P53 mutations. high copy number alterations, and again, serous carcinomas would be the prototypical example, but other subtypes have been categorized as a copy number high subtype as well. And why do we care about these 4 subtypes? It's because progression-free survival is different. So the copy number high has a poor prognosis, poly and copy number low subtypes have a relatively good prognosis. And in addition, poly and MSI high subtypes can be treated with immunotherapy. And as you know, the poly subtype can be potentially spared chemotherapy. This is just a summary of what I just discussed. And just to emphasize that we can get some clues about what subtype this can be morphologically, but of course, this is not 100% accurate, but MSI high subtype often has heterogeneity, tumor infiltrating and peritumoral lymphocytes, mostly endometrioid, but with some heterogeneity. So polymutated subtype is endometrioid, but it can have serous-like areas, and it can have heterogeneity, tumor giant cells, as shown here, and tumor infiltrating and peritumoral lymphocytes. Copy number low subtype would be your typical low-grade endometrioid adenocarcinoma, although other histotypes can have been classified as well as copy number low. And then this is just serous carcinoma as an example of copy number high subtype. So how can we identify these 4 subtypes? We really need 3 things. Immunohistochemistry for MMR is 1, immunohistochemistry for p53 is 2, and polymutation testing, last but not least, and probably the most important and the least available test would be polymutation testing. So if we use the PROMIS classifier, we can start with MMR-IHC and then move to poly and then p53. So that's one way of doing this. If we use the NCCN guidelines, we can start with poly sequencing. If poly mutations are present, then it's a poly subtype. If they are absent, then we do DNA, we do MMR-IHC. If it's deficient, it's the MSI high subtype. If it's MMR proficient, then we do p53-IHC. And then based on the presence of aberrant expression, we diagnose a copy number high versus copy number low subtype. This is just to remind you, again, aberrant p53 patterns. The most common one would be overexpression, usually almost in 100% of cells, but we require 80. Null pattern or complete absence of staining in the context of positive internal control, and the rare cytoplasmic staining as shown here on the right. So those would be all aberrant staining patterns. And the wild type staining is really heterogeneous staining with usually weak to moderate intensity. So in terms of poly testing and how it's not widely available on this continent at least, and many other countries share the same issue, one way to tackle this would be to use a modified PROMIS classifier or modified or restricted protocol, where there is this nice diagram that we can follow where we really do morphologic assessment. If we have a low-grade endometrioid adenocarcinoma and it's MMR proficient and p53 is wild type, you can argue that maybe this is not going to be polymutated and maybe poly testing is not required, especially if it's not accessible. If we have any of the non-endometrioid subtypes, such as clear cell or serous or dedifferentiated or undifferentiated, or we have grade 3 endometrioid adenocarcinoma or any MMR deficient carcinoma or p53 abnormal carcinoma, then we would need to do poly testing to make sure that we don't have secondary p53 abnormality to polymutation. And then, you can follow this guidelines and sort of eliminate the need of doing poly testing, at least in the first subgroup of patients. Of course, this approach is not perfect because you can still miss some cases. And in the ideal world, we would need to have all 3 tests, poly sequencing, MMR-IHC, and p53-IHC available to really accurately classify every single endometrial cancer. Now, HER2. So HER2 therapy or anti-HER2 therapy is important because When we look at the current NCCN guidelines, preferred therapy for HER2 positive, advanced stage, or recurrent endometrial serous carcinoma and carcinosarcoma should include an anti-HER2 targeted therapy that is trastuzumab. HER2 testing recommendations, again based on the NCCN, include HER2 testing in all endometrial serous carcinomas and carcinosarcomas, and the suggestion is to also consider it in any p53 aberrant endometrial cancer, regardless of histotype. And that has to do with the fact that progression-free survival is improved if you add trastuzumab to the regimen. So it's all treatment-driven. So of course, to determine eligibility of these patients, we would need to do HER2 testing that includes immunohistochemistry and fluorescence in situ hybridization, or FISH. And there is a number of antibodies and FISH probes available to make this happen. So we have a subset of serous carcinomas, carcinosarcomas, and clear cell carcinomas that are positive for HER2. And it happens to be associated with aberrant p53 expression, so you do understand the NCCN recommendation. Unlike breast cancer, what's important to note is that it can be quite heterogeneous. As shown in this picture, you can have some fragments that look positive, and you can have some fragments that look maybe 1+ or 2+. And also, what's important to note that in many cases, the staining is not circumferential, as shown in this picture here. It lacks apical staining in many tumor cells, so we get this lateral basolateral staining. And these are the recommendations for IHC scoring. 0 is, I'll just move to the examples, which you will see the same scoring guidelines. It's based on a clinical trial that was performed. In score 3, we expect intense complete staining in 30% of cells, 30 or more percent of tumor cells. In 2+, we have complete or basolateral lateral staining in 30% or less tumor cells, or weak to moderate staining in at least 10% of cells. Then 1+, it's really incomplete staining in less than 10% of cells, so you have some staining but not much. And then no staining is observed in score 0. And so this is just a diagram that summarizes what I just told you, and also tells you that only IHC 2+ cases are reflex to FISH, and the guidelines for FISH are as follows. So we look for HER2 Sep17 ratio of at least 2, or if the ratio is less than 2, then we need an average HER2 copy number of at least 6 to call this HER2 amplified. And these guidelines are included in the latest College of American Pathologists biomarker protocol for gynecologic cancer. So what's important to note is that sometimes there are some cases that have genetic heterogeneity in addition to immunohistochemical heterogeneity. Cluster amplification can involve the groups of tumor cells, and if the cytogeneticist who scores these cases, they need to identify cells that have gene amplification and then count 20 cells around that. So basically what this means is that you can have a tumor where most of the tumor lacks gene amplification, but you can get clusters of cells that have gene amplification, and those should be counted separately. And then mosaic amplification is just random single cells. Most of the tumor is negative, and you may see random single cells that have gene amplification. That's probably less relevant and important than cluster amplification, where if you count 20 cells and you're getting a ratio of more than 2, you're going to call that amplified. And if you just have 2 cells in the entire slide that have gene amplification, that's not going to give you a ratio of more than 2. So that's going to be negative, most likely. And the last thing I'll mention with HER2 is that one of the major findings that were presented at the last ASCO meeting was that we have this antibody drug conjugate, that's TDXD. It showed some really good results in patients with HER2 expressing solid tumors that included endometrial, cervical, and ovarian cancer. The treatment response varied from 37 to 47%, and those cases were 2+, and some of them were not gene amplified. So some of you may be familiar with this new concept of HER2 low breast cancer. So there might be something like HER2 low ovarian cancer or HER2 low endometrial cancer. In general, HER2 low GYN carcinomas may be treated also in the future with this antibody drug conjugate. I think there is more work to be done in this area. And the last two tests I'll talk about are HRD testing and FR alpha testing. So high-grade serous carcinoma is the most common type of ovarian cancer that can be associated with BRCA mutations. And these are just cancer risk quantified in mutation carriers. So we know BRCA1 and 2 are tumor suppressor genes, and they're associated with an increased risk of breast and ovarian cancer. And we care about these two genes because they are part of this homologous recombination complex, and they're important in the DNA repair by homologous recombination that repairs double-strand breaks. So what is HRD, and what does this have to do with BRCA1 and 2? So homologous recombination deficiency is defined as the presence of either BRCA1 and BRCA2 mutations and or genomic instability, which is defined as loss of heterozygosity and other genetic alterations. So one or the other, either gene mutation or genomic instability, would be sufficient to say that any given tumor is HRD positive. 50% of advanced high-grade serous carcinomas are HRD positive. What's important to note is that only half of these tumors have gene mutations, BRCA1 and BRCA2 mutations. The remaining half can only be identified by testing for genomic instability. So it's important to have a test that has both. And the current NCCN guidelines recommend HRD testing in all patients with pathologically confirmed ovarian cancer. Usually that includes high-grade serous carcinoma, possibly high-grade endometrioid. Testing can be done on blood samples that will reveal germline alterations or tumor tissue that will reveal somatic alterations. And we care about HRD status of any given tumor because these patients can be given PARP inhibitors. And that's usually in advanced stage patients with platinum-sensitive disease. How do PARP inhibitors work? If you look at any normal cell, these cells have base excision repair mediated PARP pathway and BRCA-mediated homologous recombination pathway. If we have a cell that has BRCA mutation, it doesn't have the homologous recombination pathway active, it only has the PARP pathway active. So if we block the only way that's left, then the cell is going to die due to synthetic lethality, and that's how we get clinical outcomes in these patients. So there are these prospective trials, Solo, Paula, Prima, and Velia, that have shown some response to PARP inhibitors. And there is this number of commercially available HRD tests that are listed here. As you can see, only my choice is recommended by ASCO and NCCN guidelines for tumor tissue. And you can see that HRD markers are slightly different. But if we had to really compare these tests, irrespective of which company does them, the my choice tests is probably the most comprehensive test for genomic instability as well as BRCA mutations, and can identify more patients that can be eligible for PARP inhibitor therapy. And this is getting even more complicated. There may be some functional assessment assays that can be added to this list. For example, RAD51 is part of the same complex as the BRCA1 and BRCA2 genes, and one could potentially do some functional assays to figure out whether some of the patients could be additionally eligible for PARP inhibitors, depending on the number of RAD51 foci. And a few words on FR alpha testing. Most high-grade serous carcinomas are initially platinum sensitive, and after they recur, after a few years, they become platinum resistant. And the question would be, are there any treatment options for platinum resistant disease? So yes, the current NCCN guidelines recommend this antibody drug conjugate, MIRV for short, for recurrent platinum resistant tumors that are positive for folate receptor alpha. And this is recommended as targeted therapy as a single agent or in combination with VEGF inhibitors. So folate receptor alpha mediates folate transport into epithelial cells, and it's required for basic biologic functions in cells. It's expressed in ovarian, fallopian tube, and endometrial cancers, and it's associated with tumor progression and prognosis. What's important to note is that there is only limited expression in normal tissues. And this single-arm phase 2 study, Soraya, showed treatment response rates of about 32%. So recommendations are based on this study, and there are some additional studies that are ongoing. So how do we assess this? It's actually a simple immunohistochemical stain. And the recommendation for scoring or for calling a positive result is based on the 75% cutoff. So positive result is at least 75% of viable tumor cells showing at least moderate membranous staining. It's as simple as that if you remember what the cutoff is. We can use normal fallopian tube tissue as a positive and negative control where we expect staining on the luminal surface. And if you have this available in your lab, you can also use a case with moderate circumferential staining as a positive control. These are some really straightforward examples of almost all tumor cells showing strong membranous staining. And then any staining that's less than 75%, some examples from the company where you would call this negative, even though there is strong staining on the right-hand side, it's less than 75, so it's considered negative. And Vendana gives you this really detailed diagram, which is very similar to really interpretation of any other immunostains, where you really want to make sure that your controls, negative and positive controls, worked well. And then you look at your tumor cells and you keep the 75% cutoff in mind. And any staining that's less than that is negative. And any staining that's at least 75% with at least moderate staining intensity is considered positive. So that concludes this summary of prognostic and predictive markers. As you can see, all the markers that I discussed really guide treatment decisions in some way, and they can be considered predictive, but they are also associated with prognosis or the natural history of disease. And there may be different availability in different labs, different institutions for all these tests, or some of you may have all of them available, but just to give you an idea, what are the most important tests in GYN pathology on October 31st, 2023, and I'm sure that things will change and get better in the near future. Thank you so much for your attention.
Fantastic. Thank you, Dr. Turashvili, for that presentation. Again, we're very glad you were able to come to this platform and present with us today. At this time, we would like to welcome any questions. You can enter a question by clicking on the ask a question box. So I'll allow some time for some questions to flow in here. We'll start with this one, Dr. Turashvili. Do you perform HER2 testing on endometrial cancer reflexively or only upon a clinician's request?
Okay, so for endometrial cancer, we actually do reflex HER2 IHC on serous carcinomas and carcinosarcomas, and they do align with the NCCN guidelines as well. And if you remember, they also recommend HER2 testing in any p53 aberrant endometrial cancer, whether they are serous carcinoma or carcinosarcoma, but we don't do that. Clinicians seem to always want serous carcinomas and carcinosarcomas tested. Lately, I started testing p53 aberrant clear cells. The one case that I recall from 2 weeks ago, it was actually 3+ by IHC. It was p53 aberrant. And if you remember from the talk, HER2 protein overexpression or gene amplification tends to be associated with aberrant p53. So it all made sense, but it was just diffusely and strongly positive. So it was 3+. So something to consider, but I don't know if clinicians would necessarily act on this or not, but if they need it, the information is there. So serous carcinoma and carcinosarcoma, to summarize, is what we test reflexively.
Okay. Thank you. Another one for you here is for PD-L1 testing. Do we need to use the 22C3 clone, or can other antibodies be used?
Well, so the FDA-approved clone is really 22C3 clone. So if we follow the FDA approval, that's the clone that we are supposed to use. But I'm aware that there are some labs that use other antibodies, but they had to go through extensive validation of that different antibody and really compare it. I'm not sure how exactly they would do that. Possibly they could use maybe other labs or help from other labs to compare their results with whatever antibody they're testing with the 22/3 clone, and to really make sure that they are not getting too many false negatives or too many false positives. And then, if I reported PD-L1 using another antibody other than 22C3, I would really have a good disclaimer included in my report to say that this is not the FDA-approved clone, but it's been extensively validated, and then I would call it maybe a lab-developed test. And I would say it's our lab-validated or lab-developed test with high concordance with the 22C3 clone, just to make it clear that it's not the FDA-approved clone that was used. So otherwise, okay. I think if you get high concordance, it's probably fine if there is no option to validate 22C3 in your particular lab.
Very good, thank you. I think we have one more here. For HRD testing, if a patient has for HRD testing, if a patient has a known germline mutation, do we still need to do tumor testing for genomic instability?
Okay, so that's a good question. So remember that the definition of HRD or homologous recombination deficiency is either BRCA1 or 2 mutation and or genomic instability. So if one of them is present, one can argue that it's not really necessary to test for genomic instability because the patient would be eligible for a PARP inhibitor based on the presence of germline mutation. If one wants to know if there is high genomic instability, it can possibly be done. But in terms of eligibility for PARP inhibitors, that's probably not required.
Okay, very good. I want to give one last opportunity for any further questions from the audience. So I'll just pause for a moment.
Okay.
And it doesn't look like we have any others coming in, so I think we'll go ahead and close it there. Thank you so much, Dr. Turashvili, for presenting with us today, and for the audience for taking time out of your schedule to join us. Keep an eye out for future events in this space. Again, this is the Precision Medicine in Solid Tumors space, virtual space, and you can go and check out all of the other webinars that are hosted in this site. They're recorded and posted here, as well as the exhibit hall and poster hall. We encourage you to navigate to those as well. Dr. Turashvili, thank you again for being with us, and have a great rest of your day, everyone.
Thank you for having me. Thank you.